Good morning, everyone. Today my topic is on glaucoma in aniridia. It's not moving. As you all know, aniridia is a less common familial bilateral disorder which is of autosomal dominant inheritance. Glaucoma in aniridia can be of either an open angle or a closed angle, wherein the irregular strands arising from the iris trauma, it attaches to the angle wall. When it becomes thicker and it moves forward, it causes obscuration of trabecular meshwork, scleral spur, and the ciliary body, and then ultimately the iris stem gets tilted and the angle gradually gets closed. The purpose of our study was to understand the incidence and the management techniques of glaucoma in aniridia in children. This was a retrospective analysis of 22 eyes of 11 children. We defined the glaucoma as elevated intraocular pressure of more than 21 millimeter of mercury with a cup disc ratio of more than 0.6 with specific changes in NRR as such as thinning or notching with or without RNFL defect or a disc asymmetry of more than 0.3. And the treatment success was defined as reduction of intraocular pressure of less than 21 millimeter of mercury with or without AGMs. We recorded these parameters like demographic details, tonometry, gonioscopy and fundus examination, visual acuity and slit lamp, and of course the various management techniques. The age at presentation to our clinic was around, the median age was around 4 years, and there was a male preponderance with 63.6% being males. 2 of our 11 patients had a positive family history. Varied ocular presentations were noted in our group of patients, and 50% of the aniridic eyes had moderate to severe visual impairment. When it comes to the management, 11 of our aniridic eyes with glaucoma, 7 had a good treatment, successful treatment with 5 medical therapy alone, 1 with trabeculectomy and 1 with an Ahmed glaucoma valve implantation. Unfortunately, 4 had refractory glaucoma. When we plotted in Kaplan-Meier survival of aniridic glaucoma eyes treated medically or surgically, there was fall in intraocular pressure control to 80% in 1 to 1.5 years of treatment initiation. As you all know, the prevalence being very rare, which is around 1 is to 47,000 to 1 lakh, aniridia is a rare clinical disorder which features a lot of various ocular associations, which can be keratopathy, cataract, and of course glaucoma. Our median age was around 4 to 7 years, which was almost close to a review by Netland et al., which when in his study where he has noted around 8.5 years. 85% of the patients had moderate to severe visual impairment or blindness with BCVA of 20 by 100 or worse. This was similar to studies done by various authors like Angma et al., Shenlak et al., and Leet et al. The reported incidence of glaucoma is around 6 to 75%. In our study, glaucoma occurred in 50% of the aniridic eyes. 17 of the 22 eyes were treated with AGMs, including 3 eyes which were already on AGMs at presentation, of which the optimal IOP control was achieved in 4 eyes with medical therapy alone. Most of the eyes, 10 of the 17 eyes, required 2 to 4 AGMs, while 7 of 17 eyes required less than 2 AGMs. As I mentioned, the 7 eyes achieved. So the post-trabeculectomy bleb, we had 1 successful and 1 failed trabeculectomy and 1 failed AGV. So 59% of our aniridic eyes used visual rehabilitative measures, which included monoocular telescopes and dome magnifiers. Conclusion being, management of glaucoma is an enigmatic challenge, but it is important to visually rehabilitate these children also so that we give an holistic healthcare treatment. Thank you.
Any role of CCT in measuring IOP in such cases?
The challenge was some of these patients only we could examine in the OPD. So the CCT measurement we have taken it, but most of the time they have slightly thicker corneas in aniridic children.
So that's what in such cases you have to.
Yeah.
And the role of goniotomy in early cases?
Personally, I have not tried goniotomy in any of these patients. Not very sure because most of the time there is an anterior insertion of the iris. So then goniotomy may be challenging in these kind of eyes.
You said that you performed RNFL analysis in these cases, in all cases?
No, sir. No, only whichever patients we could check in the OPD, not the very young children. The ones which are like above 8, 7, 8 who were cooperative in the OPD only we could perform.
You think
Otherwise, we couldn't
you think
perform the
that
babies.
OCT data is
Not,
compatible with this kind of age group?
not really, sir.
So
OCT analysis only clinically if you are seeing any kind of an RNFL defect more than the OCT changes.
This is a retrospective analysis, no?
Yes,
How
sir.
long have you kept these people in follow-up now? How many years now?
Average of almost 6
6 years,
years.
and they're
Yes.
doing well, most of
Yeah,
them.
yeah. Like few are refractory. We
4
have
were
done a
refractory,
CPC.
but
Yes.
otherwise the others are done well.
Yeah.
Vision improved.
Vision wise, whatever maintained, they could get, they have maintained, and we have done a visual rehabilitation, which they be using. Some of them are using dome magnifiers and telescopes. 50% had a visual impairment.
Okay, thank you.
Thank you.
Madam Chairman, distinguished panel, I bring to you the clinician's perspective on the treatment of OSSN with topical interferon from the lovely city of Jodhpur, jewel of the great Indian Thar Desert. So as you know, OSSN is the most common ocular tumor found on the surface of the eye and occurs mostly in the elderly age group. It's actually an umbrella term which encompasses a big spectrum ranging from dysplasia to carcinoma in situ to invasive squamous cell carcinoma. So we had this case, a 64-year-old male who presented with a diffuse, thick, gelatinous perilimbal vascularized mass involving all quadrants of the bulbar conjunctiva and limbus with loss of ocular surface integrity, as you can see in this picture here. The picture resembled limbal stem cell deficiency with conjunctivalization. He was being treated elsewhere as a case of unilateral allergic conjunctivitis for 2 months prior to our visit and was taking steroid eye drops and even oral steroids. The vision in the unaffected eye was 624 and it had a cataract. And in the affected eye, which you can see here in the picture, the vision was half meter counting fingers. A clinical diagnosis of diffuse OSSN was made and a biopsy was done to confirm the diagnosis. And the patient was put on lubricants and interferon eye drops 4 times a day. So this is another picture of the same patient. In the inset, you can see that the lesion doesn't pick up any fluorescein stain, but the blue light highlights the extensive surface damage on the cornea. Now the lesion started regressing with restoration of corneal clarity within 2 weeks, which was very surprising for us. At the end of 5 weeks, there was complete resolution of the lesion and the visual acuity improved from half meter counting fingers to 636. At 8 weeks, there was complete resolution of the lesion, and interferon eye drops were continued for another 2 months after clinical resolution. There has been no recurrence noted at follow-up at 6 months, but now we have this patient under follow-up for 1 year with no recurrence at all. And here is another picture, a close-up of the cornea showing the excellent resolution of the diffuse OSSN with restoration of corneal clarity. This picture was taken at 5 weeks, and the inset at the bottom shows corneal clarity with some residual corneal opacities. So interferon, ladies and gentlemen, is a naturally occurring glycoprotein which binds to cell surface receptors and has anti-tumor and antiviral properties. And interferon eye drops have been found to be remarkably effective in treating OSSN, and with a very low recurrence rate ranging from about 0 to 4%, as has been reported in literature. Now, the key thing to note here is that 15 years ago, I was reading papers in various international journals about the use of interferon in the treatment of OSSN. But at that time, interferon was terribly expensive in our country and we could not use it. But in recent years, in the last 2 years, it has become very affordable, very inexpensive and cheap, and easily available all across the country in injectable form from about 900 rupees to 1700 rupees. So that is the important take-home message, that we now have a cheaply available interferon in our country. So the question now is, how do you compound interferon eye drops? And The strength used for treating OSSN is 1 million international unit per ml. And commercially, the injections are available in strengths of 3 to 5 million international units. So for 1 ml of 1 ml of distilled water, 4 ml of distilled water should be put.
Your time is up, please.
All right, I'll just wind up. The key thing to remember here is that you have to refrigerate the drops once you compound them. And in conclusion, we've successfully treated OSSN, diffuse OSSN with interferon eye drops. It is very inexpensively available in the country now. Thank you very much for your attention.
Nice presentation, sir. But what was the strength which you used for your study, in your case, of interferon?
1 million international units per ml. Yeah.
Sir, did you do an anterior segment OCT for before and prior and end of it?
No, unfortunately, I don't have an anterior segment OCT in my practice. So
yeah, it's basically a gross this thing that it is improved.
oh yes, yes, we didn't perform any OCT because we don't have one.
How long was the patient followed up for recurrence?
1 year now.
Any role of MMC and 5FU?
Oh yes, there certainly is, but they are more toxic than interferon. So that's why current literature supports the use of interferon rather than MMC and 5FU.
Thank you, sir.
Good morning, my respected judges and dear colleagues. Myself, Dr. Shanchari Sharkar, presenting before you effect of ethambutol on retinal nerve fiber layer thickness and central macular thickness. As we all know, ethambutol has been extensively used as a first-line as well as second-line anti-tubercular drug, and this usage has been associated with a sight-threatening side effect known as ethambutol-induced optic neuropathy. The tests used to diagnose the early changes of subclinical toxicity include visual acuity, color vision, visual fields, VEP, retinal nerve fiber layer thickness assessment by OCT. The purpose of our study was to determine the changes in RNFL thickness and central macular thickness due to this optic neuropathy in patients receiving anti-tubercular treatment to help in early detection of the toxicity. It was an observational descriptive prospective cohort study conducted in the Department of Ophthalmology and Respiratory Medicine of a tertiary care hospital for a duration of 1 year after taking proper ethical committee clearance. Patients who met the inclusion criteria were referred by the Department of Respiratory Medicine to our OPD for enrollment after taking informed consent. For all the patients, we conducted a routine ophthalmic screening comprising visual acuity, color vision, pupillary reaction assessment, fundus evaluation, RNFL thickness, and CMT measurement using OCT. This workup was done at the first visit, that is before starting the drugs, then repeated at second visit, that is after 2 months, and at third visit, that is after 4 months. The patients and their relatives were counseled in details regarding the signs and symptoms of the toxicity to ensure their safety and also to improve adherence to the study. We had no financial interest. Total 22 patients were selected for the study, among which 12 were male and 10 were female, with a mean age of around 34.5 years. All the patients to start with had normal vision of 6/6 on Snell's chart. This table shows the baseline values of various variables at presentation, like the visual acuity, the central macular thickness, and the mean RNFL thickness quadrant-wise. Here we can see the progressively decreasing trend of the mean quadrantic RNFL thickness for all the quadrants over the 4 months. Here we can see the central macular thickness have increased progressively with time. This slide shows a OCT report of a patient showing RNFL thickness before and after 4 months. And here also we can see the same pattern, that is a decrease in thickness in all the quadrants. Here we can see that the central macular thickness has increased compared to the baseline. Tafner et al. In a previous study found that 2-month standard treatment and 9 to 12-month extended treatment led to a significant reduction in the RNFL. Similarly, in our study also, statistically significant RNFL thinning was noted in all the quadrants at the end of 4 months. While thinning in nasal quadrant was significant throughout the study, in other quadrants, the thinning was significant only during the first 2 months, that is the intensive phase. Lee et al. Found a significant difference in average and all quadrants macular GCIPL thickness between the control group and the optic neuropathy group. In our study, the central macular thickness increased significantly at the end of 4 months. We may conclude that ethambutol has deleterious effect on optic nerve as well as macular region as evident from this study. Early and regular screening of the patients undergoing antitubercular therapy containing ethambutol with OCT seems to be an effective endeavor which can help us in early detection of the subclinical toxicity. We have to be more careful about starting ethambutol in patients with pre-existing macular edema, macular disease, or in people who have an increased propensity for macular edema. Thank you.
So what is the minimum dosage of ethambutol where you expect this toxicity?
Sorry, sir, I couldn't.
What is the dosage of ethambutol where you expect this toxicity?
Actually, for this paper, we did not correlate with the dosage, but it can be even seen in 15 mg per kg, as low as 15 mg per kg per day. Even in that cases, we can, according to the previous studies, we can see incidence of optic neuropathy.
Your OCT picture was showing some white quadrants there. What does that mean? After 4 months, you showed that there is some decrease in RNFL, but 2 quadrants were white in color.
Sir, in the
Yes, your quadrantic map was showing that. So what do you infer from that? Okay.
How do you explain the macular toxicity of ethambutol?
Ma'am, actually, this result was even surprising for us because in the previous studies, mainly in the macular part, we have noted that there is a reduction with time. But in this, though it was a short, the sample size was not very big. It was only 22 patients, so 44 eyes. But we noted the difference was, we noted an increase in central macular thickness. We are not sure what is the reason because actually previous studies did not find such finding. But it was clinically insignificant, but statistically there was a slight increase in central macular thickness that we don't know how to explain.
It's not a measurement bias, huh? RNFL.
Yeah, measurement bias is possible. Has the same person taken the OCT of all these patients repeatedly?
Thank you.
Yeah, next, Dr. Arvind Roy.
Hello, good morning. Can I start?
Yes, sure.
Okay. So, esteemed judges on the panel and my dear colleagues in the audience, good morning to all. Our study for today is the outcomes of infectious scleritis, analysis of 17 years of data from a referral corneal service. We do not have any disclosures or conflicts of interest. Scleritis typically is classified as infectious or non-infectious. Non-infectious is the immune-mediated variety, and infectious could be exogenous or endogenous. The varying incidence has been reported between 5 to 18% in different studies. We conducted a retrospective chart review from January 2005 to December 2021. It was conducted at 4 different tertiary centers of LV Prasad Eye Institute. We studied 82 eyes of 82 patients. There was a male preponderance. Typically, the demographic profile constituted of agricultural workers, and trauma and diabetes were the common risk factors. At presentation and the last follow-up, the best corrected visual acuity was categorized into 2 categories, less than 2200 or better than 2200, and in either of the category we did not find any significant difference. Bacteria was the commonest organism. In addition, we found that adjacent tissues such as a concomitant keratitis was noted in 37 eyes and a VR involvement in 14 eyes. The odds of a corneal versus a VR involvement was 2.46. Scleral deroofing was the commonest diagnostic and the therapeutic modality. I will show this basic procedure of scleral deroofing, which is very useful in managing infectious scleritis, and there are 3 key points that one needs to take home from this procedure. Number 1 is excising the conjunctiva adequately. Is there an issue with the video? Okay, so in the interest of time, one needs to excise the conjunctiva adequately, cauterize all the bleeding points, make a cruciate incision at the peak of the abscess, and marsupialize it. I'm sorry for this video not playing. I'm not sure what is the technical error. Okay, I'm trying to go to the next slide. It's fine. Thank you. No, let it be. It's fine. We are running out of time. It's not required. It's not required. Let it be. It's a very basic procedure. Many people do that. Yeah, if you can just give me my slides, I think we are just closing now. So the outcomes were that all except 11 eyes resolved with medical treatment, and those 11 eyes required evisceration. The mean duration of treatment was 7 weeks. What we found when we compared this to the other studies are that predominantly there was bacterial involvement, and trauma was the commonest predisposing factor, and most of the eyes resolved well. Therefore, the conclusions or the takeaways are that this is a chronic ocular infection. It has a significant involvement of the cornea. The risks of the eye going into evisceration or the vision completely being lost are significant, and intensive timely antimicrobial treatment and early surgical debridement can salvage these eyes. Thank you for your patient hearing.
Okay, you said prior ocular surgery was one of the factors.
Prior ocular surgery was a less common factor.
Okay,
It was
what was the surgery which was led to this kind of a scenario?
So some cases were the pterygium excisions, some were cataract surgeries, but what was the most common fear? The risk factor was trauma.
Okay, trauma we know, but you see, surgeries we are performing day in, day out.
Yes.
So what message do you have?
So since the surgeries
to prevent this scenario,
I think it will be early identification and probably looking at those surgeries where there is an exposure of the sclera, where there might be a possible nidus of infection, meaning that this can, when we say it is related to surgery, number one is the kind of sterility that is performed, the asepsis or the periocular asepsis that is performed for prophylaxis, and the second is that the post-operative regimen needs to be very meticulous.
I think cauterization used to be a very important factor, and I don't know, but what about your research is not highlighting anything?
Used to be a factor.
It used to be, yes, we
this
agree.
Trauma thing, which is it a scleral injury you're talking about?
Yes, it's a foreign body, possibly either a blunt trauma or something which is sustained during a road traffic accident.
Blunt trauma caused infectious scleritis.
Meaning that when there is a trauma to the eye, which could either be a full thickness or a partial thickness trauma, where there is a kind of a maceration of some of the layers of the ocular coats, then that were some of those predisposing factors we found in our analysis.
And how many days after does this present?
So typically these were about 1 to 3 to 4 weeks after the trauma.
So would suturing have initially, suturing would have helped in this?
Yes, it's quite possible it might have.
Okay, thank you.
Sure, thank you very much.
Dr. Nina R.
So, warm good morning to one and all. Diplopia after cataract surgery, when binocular vision becomes a bane than a boon. So, we know that cataract surgery is the most routinely performed surgery in modern ophthalmology with spectacular results and high expectations. So, diplopia post-cataract surgery is a major distress to the patient and a big surprise and disappointment to the surgeon. So our study aimed to evaluate the causes of binocular diplopia following cataract surgery. No financial interests. So this was a retrospective electronic medical records analysis of all those with binocular diplopia who presented within 6 weeks of cataract surgery at our center from 2015 to 2021 with a minimum follow-up of 1 year. So the parameters analyzed are listed on the left-hand side. So coming to our results, we had about 30 males and 8 females in our study. The mean age was 72.4 years. All had uneventful cataract surgery, majority undergoing phacoemulsification with IOL, and all had a peribulbar block anesthesia. So what we found surprising was pre-existing diplopia constituted the chunk of the cases, with 65.79% having pre-existing diplopia, and new onset diplopia was seen in about 34.21% patients. What was even more surprising was 10.53% in 10.53% patients, we missed the diplopia pre-operatively. Majority had horizontal diplopia, as you can see here, followed by vertical, and then a small series of patients having combination of both. What was even more surprising was 73.7% patients complained of diplopia on looking towards the operated eye. So pre-operative Würzburg evaluation detected diplopia in 42.1% patients. Squint was seen in 55.2% patients preoperatively, and diplopia charting revealed diplopia in 20 patients. So most of the pre-existing diplopia in our cases were decompensated foria to tropia, mainly exophoria to exotropia, whereas the new onset diplopias were mainly cranial nerve palsies, majority being superior oblique palsies. We had one patient each with post-scleral buccal surgery, ocular myasthenia, and local anesthesia-induced diplopia. So preoperative systemic risk factors were seen in 36 patients, with majority having more than one risk factor. So in interim management, majority opted for prism glasses. As you can see here, this gentleman with intermittent exotropia going into a right exotropia, and this patient with a superior oblique palsy wearing prism glasses. 10.5% opted for orthoptic exercises and monocular occlusion respectively. Those with myasthenia were treated with medical management, and the rest were asked to wait and watch. In the definitive management, 71% had relief from diplopia, 15% made spontaneous recovery, 29 patients used prism glasses, 23.68% underwent squint surgery. As you can see, the gentleman with left superior oblique palsy post-surgery, and this lady with very nagging diplopia, very comfortable after squint surgery. 2.6% needed squint surgery along with prism glasses, whereas the others deferred treatment. So to discuss, out of the 48,500 patients who underwent cataract surgery, only 38 patients, that is 0.078, had binocular diplopia with recorded, recorded in our hospital. This is a small number, but nevertheless significant, and patients often attribute diplopia to the surgery. So majority were pre-operative existing diplopias, some were missed. The new onset ones were mainly superior oblique palsies. Local anesthesia-induced diplopia was very rare, and pre-operative missed diplopia constituted about 10% patients. A good binocular evaluation pre-op was able to detect most of the diplopias. So I'd like to conclude by saying that it is infrequent, but can be a major source of distress to the patient, and a good pre-op binocular evaluation and a post-op binocular evaluation will help you to get avoid a post-op surprise. Thank you.
Yes, you did only peribulbar or topical also?
All these patients had peribulbar anesthesia.
So you didn't have any topical cases?
No, in this series we didn't have any.
So do you think any problem can arise after topical also?
Yeah, it's because in our series, the anesthesia-induced diplopia was only seen in one patient, in which the inferior rectus apparently underwent injury due to the block, and that patient needed prism glasses. But it can be now, as I showed, most of the cases of diplopia in our series were pre-existing phorias which broke down to tropias, and when either they were detected already but were not explained properly, or they were explained or they were missed, or some of them were pre-existing cranial nerve palsies like superior oblique palsies, which the patient couldn't explain properly whether it was due to a defective vision or a double vision, and it was missed or it was understood, but we were able to detect it post-op.
Do you treat them immediately, or do you want for some time after cataract surgery to treat them?
Yeah, we actually waited till about the glass appointment. That would be like 2 to 3 weeks post cataract surgery. So when they come for glass appointment, if they have diplopia, they would be definitely symptomatic. So that's the time we usually evaluate it. We evaluate pre-op also, but post-op we ask them, they give them the option of prism glasses. But if it's very symptomatic, we definitely give them the option of prism glasses, because that's very, very disturbing to the patient, and patient is very upset because they have excellent vision, but they're seeing double. They are extremely unhappy.
And out of your 38 cases, how many were advanced cataracts?
Yeah, that's what. So most of the patients in our surgery had a best corrected visual acuity of better than or equal to 6/60 in the worst eye, That is the reason why I'm stressing that we should do a preoperative binocular vision evaluation. Only very few patients had poor vision of less than or equal to counting fingers. So it is still possible to do a binocular vision evaluation in all these patients, at least by a squint evaluation, cover test, or a diplopia charting. If you notice a squint, you should definitely ask for diplopia.
Even with counting fingers?
No, in counting fingers, I do agree you cannot. But majority had a vision of at least 6/60 or better in the worst eye.
Actually, cataract surgery is incidental in this, no? According to you.
Pardon?
Basically, the reason is not cataract surgery.
No, that's what I'm saying. But the patient will attribute the diplopia to the surgery.
That is true. But this entity is only an incidental finding because you are an expert on squint and it was referred to you.
No, what I wanted to see is I get a lot of referrals from the cataract surgeons after surgery for squint and diplopia. So I just wanted to highlight this fact that please do a binocular vision evaluation before.
This is not a condition we usually get.
And ideally speaking, we should not have included the pre-existing diplopia cases.
Yeah, because that's patient can actually sue you, saying that I have opted for.
Like the topic
when you're
was
presenting
different.
a case series, I think, I mean, it's not attributed to the surgery.
The topic is different.
No, what I wanted to say is that diplopia post-cataract surgery. My series included all the patients who came to me post-cataract surgery with diplopia. And I just want to tell you that it is not due to cataract surgery. Most of them are actually not due to cataract surgery. It is due to a pre-existing cause, which we could have explained to the patient and taken proper counseling and taken measures in the later.
Any cause you can attribute to cataract surgery in a normal case, absolutely normal case?
Yes. Local anesthesia induced. So local anesthesia induced.
How will it cause?
It can produce myotoxicity if you're injecting.
Anything else?
A trauma, suppose like superior rectus, like you're taking a superior rectus suture and you're injuring the superior rectus, that is another possibility.
Inferior rectus sutures.
Yeah, inferior rectus. Some people take inferior rectus sutures also.
In this case, like suppose it was a temporal incision, they may have done a lateral or medial rectus.
Yeah, if you take any, usually nowadays for phacoemulsification, you don't do any of these things. So in my series, most of them were phaco patients. So it is not related to surgery. That is exactly what, but the patient is going to attribute the entire thing to the surgeon. And even towards the eye, they complained of diplopia. It could be the opposite eye muscle which is involved, but the diplopia was more in that case. So the patient is attributing entirely to the cataract surgery. So I just wanted to bring this point that cataract surgeons need to do a proper binocular vision assessment before and after, or at least send a referral or counsel the patient accordingly if they have a pre-existing.
Thank you.
Thank you.
Next author, please, Dr. Helen Javeri.
Those lights are very disturbing.
I'll start.
Some sort of a signal?
Okay. Yeah. So AI and machine learning are definitely hot topics in every industry, especially healthcare as well. Ophthalmology as a field utilizes various imaging modalities, and it is only a matter of time when it is well integrated with artificial intelligence as well. But we as ophthalmologists, how are we supposed to understand whether a predictive algorithm is good or even better than another algorithm presented to us? So I, Dr. Henal Javeri, present to you parameters for evaluating an artificial intelligence model. There are no conflicts of interest to declare. So my purpose of this presentation is to summarize the key parameters which a clinician must take into account when evaluating an AI model for clinical use in ophthalmology. We performed a literature review in PubMed, Cochrane, and Google Scholar regarding machine learning evaluation metrics, and the articles which dealt with the methods for evaluation were reviewed. The most commonly used statistical evaluation metrics for AI models in the background of healthcare and clinical ophthalmology are presented as a brief overview.
So specifically in ophthalmology, there are two types of models which are commonly required. One is the classification model, the example for which could be deciding upon fundus imaging whether a patient has diabetic retinopathy or not. And for this kind of a model, what we look into account is the receiver operating curve, the area under the receiver operating curve, and the precision recall curve. Another type of model is the regression model, an example of which could be predicting myopic regression post-cataract, post-refractive surgery using pre-op data or fundus images. The parameter that we look for in this is the coefficient of determination as well as the mean squared error or the mean absolute error. So various technical terms that we do look and we must look for are the accuracy, that is the number of all corrected predictions divided by the total number of the data set. The best accuracy being 1, the worst being 0. Sensitivity or recall, that is when the patient has diabetic macular edema, how often does the test predict the same? Meaning, out of all the positive data points in a particular sample, how many did the model predict as positive? Next being the specificity, that is when the patient did not have DME, how often was the test able to pick that up? Precision, that is the positive predictive value, talks about how often is the model correct when predicting positive, and negative predictive value talks about how often the model is correct when predicting a negative outcome. Both these, that is the negative predictive value and the precision, depend on the prevalence as well, and therefore sometimes can be misleading. So the figure below demonstrates the receiver operator curve, where on the x-axis we have the false positive rate and the y-axis the true positive rate. So basically it assesses the performance of the model over an entire range of threshold. So we can decide upon this what cutoff threshold we want, and accordingly the true positive rate and the false positive rate are linearly related. In an imbalanced set, this could be misleading. Next comes the area under the ROC curve, which is just a single number that summarizes the efficacy of the model, 1 being a perfect classifier, and usually 0.5 that is chosen is a random, completely random classifier. Meaning that there would 0.5 would be the true positive rate, and accordingly false positive rate would also be 0.5. Next comes the precision recall curve, where on the x-axis we have recall and y-axis precision. So basically in this, just give me a minute. Basically in this, the number of true negative results are not used, and overall the curve which appears above the other one on comparison has a better performance. Similarly, in a regression or model, we'll have a mean absolute error, and an R-squared model would have a basically a value between 0 and 1. So in conclusion, the end goal of creating an assistive technology is to improve the service and the patient outcomes, which depends on clinicians using this tool, and it is very imperative that they understand the tool as well. Thank you.
I'm afraid I have a slight doubt. What is the study about? You did a literature review. You've not mentioned anything about what you have
Actually,
done.
there were only about 3 studies which were talking about evaluation of the various parameters in an artificial intelligence model.
So you have done a statistical analysis of these, or what?
No, so those studies were basically talking about the most commonly used methods and explaining the same for a healthcare provider. So that is what I took a brief out of that and I've presented the same.
Kind of a review.
It's a literature review, but it's not a systematic review. You just, this thing did you look for, search for, cite?
So ma'am, we've checked in PubMed, Cochrane and Google Scholar. Those
most
3.
Most of these AIs will be in the engineering groups rather than medical.
Because we were looking specifically for something related to medical.
No, it's related to medical, but it will be in the engineering stream.
Okay. What is the final message to the audience?
The final message is that in the 2 commonly used models are the classifier and the regression.
No, just one line that this will help clinicians. That's it.
Basic disease. At least in which disease in ophthalmology do you think it's better now, as of now?
There's a lot of progress with regards to diabetic retinopathy that we are seeing right now. So these models would be, there are multiple models on the same, and therefore an understanding on which model would be good and the evaluation of the same is helpful.
Have you personally used any of these systems for your?
So we've been carrying out a study regarding fundus imaging for diabetic retinopathy using such a model, but it's still, we're in the middle of publishing it, so we cannot kind of disclose the results at present. Okay. Thank you.
Dr. Avantika?
Good morning, everyone. I'll be presenting before you analysis of retinal nerve fiber layer thickness in patients of Alzheimer's disease. Alzheimer's disease, a neurodegenerative disorder, is the most common cause of dementia in the elderly. It presents with an insidious onset of memory loss followed by a slowly progressive dementia over several years. Mild cognitive impairment is considered as the prodromal stage of Alzheimer's disease, in which memory loss falls 1.5 standard deviation below normal on standardized memory tests. Recent studies have shown that neurodegeneration also involves retinal ganglion cells and their axons in the optic nerve. On HPE, lesions associated with Alzheimer's disease like neuronal loss, neurofibrillary tangles have been found in the neuroretina also. Until recently, the diagnosis of Alzheimer's disease has been on the basis of symptoms neuroimaging studies like CT and MRI and CSF evaluation, which shows no specific changes, especially in the early disease. OCT, being a non-invasive technique for the measurement of peripapillary RNFL, has been proven useful for detecting significantly reduced retinal thickness in patients of Alzheimer's disease. So the aim of our study was to evaluate RNFL thickness in patients of Alzheimer's disease using ST-OCT. This was a prospective cross-sectional study that included eyes of 32 diagnosed cases of Alzheimer's disease and control group, which consisted of the eyes of 32 patients visiting OPD for routine eye examination. Patients diagnosed with Alzheimer's disease by MRI findings and MMSE and best corrected visual acuity 612 or better were included in the study. Patients with other known diseases affecting the optic nerve with unclear media, optic disc anomalies, or history of IOP elevations were excluded from the study. Both cases and controls underwent detailed ocular examination, including measurement of BCVA, slit lamp examination, IOP measurements, CCT, and fundoscopy. All subjects underwent OCT scanning for measurement of peripapillary thickness. In our study, both the groups have slight female preponderance, 64% in the Alzheimer's disease group and 55% in the control group. There was no statistical significant difference between the AD group and control group in terms of age. In the AD group, 59.3% patients had abnormal RNFL thickness and 40.6% had normal RNFL thickness. On comparing the mean RNFL thickness between the AD group and control group, we found that AD group had significantly reduced RNFL thickness when compared to the control group. On comparing the RNFL thickness in different quadrants between the AD group and control group, we found that there was a decrease in the RNFL thickness in all the quadrants when compared with the control group. The age difference between the two groups was not statistically significant. Leon et al. In their study found that average RNFL thickness was significantly decreased in patients with AD. Similarly, in our study, the average RNFL thickness in AD patient was found to be significantly less than that of the control group. Liu et al. In their study have shown that RNFL thickness of superior and inferior quadrant to be reduced in patients of AD. In our study, the RNFL thickness of AD patients in all quadrant was thinner than controls. However, the thinning was statistically significant only in the superior quadrant. So, RNFL measurement by OCT can be used as an early and important tool to aid the diagnosis of AD. Additionally, RNFL thickness changes can be used to monitor the progression of Alzheimer's disease. Demonstrating progressive thinning of RNFL over time can be critical for validating OCT as a viable biomarker for patients with Alzheimer's disease. Thank you.
Okay, you
What
said
was the
that
cause for thinning of the superior RFNL defects in your cases?
Ma'am, we could not actually correlate why there was only in the thinning was in all the quadrants, but statistically significant only in the superior quadrant. In previous studies, there was we have seen that there was thinning in only superior and the inferior quadrant. Not thinning was not found in other quadrants.
But you couldn't reason it out.
No.
So you said that RNFL analysis can help in diagnosis, but in your series, they were already diagnosed cases.
Yes, sir.
So how do you infer this?
Sir, in our study, patients were already sent from the neurology OPD. They were
No,
already
that's okay, that we know, but how do you make this conclusion that it can help in early diagnosis?
Actually, it won't help more in diagnosis, more for progression, and that also if you know the time period when you're going to call them, you have to assess them more prospectively.
if the physicians send early to the, if the patient's presenting with dementia, early dementia, if they refer to us and we can get a OCT RNFL, then we can
So
at least monitor the patient.
that makes it a different study
Yes, sir.
altogether.
Not in the
So
study.
on the basis of this study, you cannot say this is
Yes,
just
sir.
a review kind of a thing.
Yes, sir.
Next, Dr. Pallavi Sinha. Next person then, Dr. Jitendra.
Good morning, everybody. Respected judges and dear friends, there's no financial disclosure. So we will be presenting our work on using low concentration atropine 0.05% in children who were non-responders to 0.01%. So IRB approval and ethic committee approval was taken. Who is a non-responder to 0.01%? A non-responder is a child who despite using 0.01% still progresses at a rate of 0.5 diopter per year, and so all the children who were taken into the study were progressing despite using 0.01%. All the routine investigations, ophthalmic workup, orthoptic evaluation was done, especially pupillary size, near point of accommodation and convergence, because we were using a higher concentration of atropine. Now the mean age was 6.5 years. The glass power before starting a higher concentration was increasing at a rate of 0.71 diopters per year, and after switching over to 0.05%, the progression reduced to 0.22 diopters. One patient did complain of receding of near point of accommodation, and we gave him bifocals. So the axial length growth also slowed down, but there were 4 children out of 30 who still were progressing despite using a higher concentration. And we all know now that 0.01% atropine is now used to control myopic progression. Most of the studies have shown good results. There was a wonderful case report from lamp 2 trial where they showed that axial myopia progression is indeed dose dependent. They did compare 0.01 and 0.05% and found that 0.0% was more efficacious. However, they did not use it in 0.01% non-responders. So that is where our study is of importance, that in children who are not responding to 0.01% or the rate of progression is not very good, the control is not good, 0.05% can be used there. The factors responsible in the 4 children, one of the child was very young, he was 5-year-old. 3 children had a parental history of high myopia, and out of these 3, one of the child was progressing rapidly prior to 0.05%. So the rate of progression did reduce with 0.05%, but it was still more than 0.5, and so we still kept him in non-responder to 0.05%. So in conclusion, we believe that low concentration atropine eye drops 0.05% is useful in non-responders to 0.01%. Why it is important is that it would be wise to switch to a higher concentration in children who are not responding to 0.01% low concentration atropine eye drops for preventing the progression of myopia. This is mainly for axial myopia. Thank you so much.
Any systemic side effects noted?
No, sir, not at all.
Any local?
Sir?
Any local side effects?
No local. One patient did complain of blurring for near vision. In that patient, we gave bifocals.
How long was the follow-up with 0.01?
0.01% we followed for 1 year, madam.
Only 1 year. So
Yeah. No, 1 year is more than enough. I mean, if you don't get response in 1 year, you are not going to get response. Even the ATOM 1 or ATOM 2 study.
ATOM actually said 2 years,
No, madam. For dubbing them as non-responder, they did not say 2 years. They published their results for 2 years. So it was a study done for 2 years. But we presented our data in 2018 follow-up work. If for 1 year the patient does not respond to 0.01%, the patient would not be responding in another year.
And how many years have you followed up with this 0.05?
1 year, madam. Only 1 year.
They
Yes,
have
yes.
actually responded well.
Yeah, I mean, 26 responded well, 4 still did not respond.
So the washout period is also the same concept.
The washout period of 0.01 or
0.05.
So we still don't have the rebound for that. We have not stopped them yet.
Okay. Thank you.
What age would you continue? Sorry.
Yes, ma'am.
Up to what age would you continue?
So typically, like if we go by the published results, we would be continuing till 14 years of age, but published data does say that you can continue for 2 years like Atom 2 did. With if our experience or the routine experience of clinicians, we do continue till 14 or 15 years of age. Some children we continue for 3 years also. My own data in 2018 we published or presented was for 3 years.
Were there any systemic associations also in these children?
No, madam. These were purely school myopia children. I mean, the progression of myopia was axial. There were no syndromic patients, no ROP patients, no patients like that, Marfans, nothing like that. Thank you. Thank you, sir.
Next, Dr. Punita Kumari Sood.
Honorable Chairpersons, my dear friends, I'm going to speak on correlating ocular features with serum VEGF-D and other inflammatory factors in COVID. The prevalence of ocular manifestation is 2 to 32%, and the spread is of the viruses from the mucous membrane. However, the inflammatory factors mediate the inflammation and cause severe systemic involvement as well as also involvement of eye. Huang and Kong et al. Studied that VEGF levels are elevated in patients of COVID, and they were correlated with sequential organ failure assessment. However, they did not study the ocular features. Wu et al. Studied ocular features and found that LDH and CRP and other inflammatory factors were elevated. Seeing the paucity of literature, the aim of the study was to evaluate ophthalmic manifestation and correlation with serum levels of vascular endothelial growth factor D and other inflammatory factors in COVID recovered subjects. There are very few studies on this. The study was approved by Institutional Ethical Committee and informed consent was obtained from the participants. Carried at Department of Ophthalmology, Guru Nanak Eye Center, Maulana Azad Medical College as an observational study on 160 eyes of 80 COVID-19 recovered subjects to evaluate serum VEGF-D levels and C-reactive protein, LDH, D-dimer, and ferritin. Subjects having significant ocular diseases and central nervous system diseases or other ocular surgeries other than uneventful cataract surgery were excluded. History was taken for diminution of vision, redness, irritation, foreign body sensation, and examination was done for best corrected visual acuity, intraocular pressure, dilated fundus examination, color vision, contrast sensitivity, OCT and OCTA, and 3 into 3 millimeter macular scans. 54 males and 26 females with mean age of 50 years, however they did not have any ocular symptoms. The distance best corrected visual acuity was less than 6 by 60. Intraocular pressure mean was 17. The slit lamp did not show any anterior segment inflammatory features. The Isharas plate showed normal results in majority of patients. Farnsworth showed 28, 26, and 21 to have mild, moderate, and severe trypanopia. Contrast sensitivity was within normal range of 2. The central foveal thickness was 245, and the levels of VEGF-D were almost double the levels reported as normal in normal healthy subjects. The picture shows this VEGF-D that surprisingly it is most studied parameter in the ocular diseases, did not have any significant correlation with the ocular parameters as mentioned in the left side. The CRP, LDH, and D-dimer, they had negative correlation with the near refractive error, meaning that if their level was high, the subjects had better near vision. The CRP had positive correlation with contrast sensitivity, and LDH had positive correlation with good results on the Isharas red-green plates. So if they were high, this means they were better results and higher contrast sensitivity. However, the foveal thickness was more if LDH levels were high. The D dimer were negatively correlated with the best corrected visual acuity and negative correlation with the Farnsworth test. So higher levels indicate that worse distance best corrected visual acuity and more errors on the Farnsworth. The ferritin was having a positive correlation with the distance refractive error. This means higher the levels, more the error, and worse is the distance best corrected visual acuity. On the octa parameters, the FAS parameters, they had negative correlation with the levels. This means higher the levels, lesser is the FAS area, foveal avascular zone area, and lesser is the foveal avascular zone perimeter, which indicates better health. And higher the vessel density in superficial capillary plexus, deep capillary plexus, outer retina, choriocapillaries, that negative correlation means higher, sorry, that positive correlation means higher the level, more is the vascularity. So this, if vascularity is high, this does not necessarily indicate good health, rather it may be indicating more inflammation. Thank you.
So you're saying these high values actually improved their near vision, some of these patients?
Yeah.
And how do you explain that?
These inflammatory factors also raise the vascularity. And if the vascularity is better, then the blood supply to the photoreceptors increase. There are certain acupuncture and acupressure treatment and yoga treatment which increase the vascularity of eyes in order to increase the vision. So I'm explaining in that basis. And secondly, it is seen in the literature that in earlier phases, the adverse effect of these inflammatory factors may not be visible. Since I had studied at only one stage these patients, maybe if I may have followed up for 3 months, their ocular parameters would have gone down.
But your conclusion was that vascularity does not mean that there is improvement.
Vascularity,
that is what your conclusion was.
Because our general perception is that if the person is, because this is just one stage study. Maybe if I would have studied initially, there may be increase.
They improved, no? Did you correlated those patients and that vascularity increased?
Yeah.
So it was improvement. So why did you conclude that there is no improvement?
No, it is like, that suppose we take caffeine and it improves the performance for some time, but later on it may deteriorate. It is, if we think that if the vascularity of retina is more, then a person is healthy. But if inflammation also, the vascularity will increase.
Thank you.
Thank you.
Dr. Pallavi Sinha is not present. Okay, thank you. So with that, we conclude the session. I'd like to thank all the speakers for an excellent presentation.